One of the very important applications for genetics in medicine, specifically personalized medicine, is a field called pharmacogenetics. So the question of how do drugs work in my specific body, what kind of side effects can I expect, and how can I prevent side effects and improve treatment? So it's a very popular topic. More and more clinicians start working with it. And it highlights something that we should have been doing for way longer than we already are. So it's really time that we start adopting pharmacogenetics into clinical practice. One example that highlights the importance of pharmacogenetics is this story that I talk about in my book. In the year 2005 in the US, a woman gave birth to a baby in a hospital and everything was fine. The baby was healthy, the mother was healthy. She did get some painkillers for the injuries during childbirth, but everything was fine. She started breastfeeding, the baby aged well, so everything was good. But on day 7, the doctors realized that the baby became lethargic, so less energetic. On the day 12, the skin of the baby started to change color, and on the 13th day, the baby died. So this was very tragic because a completely healthy baby quickly deteriorated and then had a fatal result. And so the doctors looked at what was the reason. Why did this baby die so quickly? They did an autopsy and they found out that the baby died of a morphine overdose. And this was very weird because neither the baby nor the mother were treated with morphine. The only clue that they had was that the mother was using a completely different painkiller called codeine for the injuries that she had. And so to understand what happened here, we're going to have to dive a little into the field of pharmacogenetics. So we're going to return to this story. Now, medication side effects are a much bigger problem than you think. Generally, if you get a drug, it only works in around 60% of people in the way that you should. Some people have no effect and others have side effects. So it's quite a big hit and miss. And with people that are in hospital, 1 in 250 that are in hospital die due to medication side effects and not to the disease or the issue why they are there in the first place. So it's quite a big issue. And this in total makes medication side effects the 6th most common cause of death in the Western world. So it's just one step behind diabetes. So it's a really, really big problem. We're just not aware of it. And that's sad because we have so much information. We could really solve quite a lot of these issues with just having the right genetic information. So we're going to dive into 4 levels of complexity in pharmacogenetics. Don't worry, you don't need a biology degree to follow. So we're going to start with a very simple level, level 1, and the principle is genes break down drugs. So if I take a drug and it gets to my bloodstream, reaches my bloodstream, it's spread throughout the body through my blood, and then it shows its effect, whatever that may be. But our body does not know this weird chemical that we've developed in our industrial age. So from a Stone Age perspective, this is a weird chemical, a toxin that's not supposed to be here. And so we have genes that recognize these chemicals and say, okay, that's not supposed to be here. And so it breaks down the chemical and neutralizes it. By changing it, chemically changing it, it targets it for the kidneys or the liver to then remove it from the bloodstream. So that's one of the processes. The gene targets it for elimination. And that's how we get rid of this substance from our body again. If you take a drug, it increases in your bloodstream, and then the body says, okay, it's not supposed to be here, and it starts to remove it again. And you can see this here, the green area is the effective blood level. That's where you want to be if the drug needs to work. You need a certain amount. And so you're in the effective range for a while and then it's removed again. It's kind of like alcohol. If you drink alcohol, it increases in your bloodstream and then the body says it's not supposed to be there and you get sober again. So this is what we're hoping that happens if you take a drug. Some drugs, of course, need to work long-term, like blood thinners and so on, not just for short-term. And so you just take a pill every day, so you're always in the active ingredient range. So all is good. Now, genetics comes along and says, okay, well, not everybody of us has such good genes. So what happens if these genes don't work in the way that we want? The drug comes in again, but this time the gene is not doing its job and is not recognizing it. So it stays in the body, it's not modified, it's not eliminated, and it just stays there. And it's usually not a problem if you take it once, but then you take it again and again and again, and then it starts to accumulate. So instead of this is what happens. With every intake, the amount increases. And at some point, you're going to reach severe toxicity because you have too much of the drug in your bloodstream and it poisons you. So let's go into the second level of complexity. And that is, there's not just one gene that breaks down all drugs. There are many, many genes that break down different drugs. So they all have weird names. So 1A2 is CYP1A2, 2C9, 2C19, and so on. And those are all genes known to break down certain drugs. And we know which drugs are broken down by which gene. So for example, the medication Tacrin is broken down by the gene 1A2. Glimepiride, diabetes medication, through 2C9. Codeine, which we're going to talk about later, is the gene 2D6, and Viagra for the men is 3A4. So different drugs are broken down by different genes. Now we can check if these genes work in the way that they should. For example, if this gene is broken, we know we've got an issue with this drug, completely independent from all the others. The others are not an issue, it's just this one and all the other ones that are broken down by this gene. Then if the gene 2D6 doesn't work, we have a problem with codeine, but not with the others. So depending on which gene is broken, it has a different effect. So one more level in complexity is genes cannot just work and not work. They can have different levels of activity. And that's quite interesting. So if we take a drug and we break it down with the gene 2D6, now from this we have typically two copies, one from the father and one from the mother. This is true for virtually all genes. There are some exceptions, but most of them we have two copies, one from mom and one from dad. So if both work in the way that we want, two good genes, the drug is broken down and eliminated, and this is done in the normal speed that you would expect. This is what the doctor hopes happens in you when he gives you a drug. And we call this an extensive metabolizer. That's 77% of the population. So 77% are breaking down this drug through this gene in the normal way. In some people, one of the two genes is not functional. I'm, for example, exactly this case. So I only have one functioning copy. One of them is broken from my father or from my mother. And the drug is only broken down half as fast because half as many workers are doing the same job. So we call this an intermediate metabolizer, and that's 11% of the population, myself included. Then there is a case where both genes are not working. And so there are virtually no conversions, so the drug needs to be gotten rid of in some other way. We call these poor metabolizers. That's 10%, still 1 in 10 people. And then there's a curious case of ultra-rapid metabolizers. The genes are doing their job way too well. So what happens is all of the drug is immediately converted and broken down. So we're breaking it up much faster than it should be done. And that's 2% of the population. So that's interesting, because what does this now mean for the right dose of my drug, of this drug, depending on the genetic type that I might have? And so, for example, if we take the drug and it's broken down in a normal way that my doctor hopes, I will need to take the normal dose. It's always worth thinking about it in terms of alcohol as well. So if I become sober in the normal amount of time, I can drink a normal amount of alcohol. In cases like myself, where one of the two genes is not working, this is only broken down half as fast. So this person only gets sober half as quickly. So what does that mean? You can only drink half as much, but for the same effect. Some people who never get sober, they shouldn't be drinking at all. There should be... So some people who never get sober shouldn't be drinking at all. And people who get sober twice as much, they can actually drink twice as much. So that's a very good way of thinking about it. So normal dose, half dose, please different drug, or double dose is all dependent on the status of this one gene for the same drug. So it's very, very interesting. You can see that these are quite common. So this affects many, many of us. So the last level of complexity, and then I promise we're done. Some drugs must first be converted by a gene to show an effect. They're called prodrugs. And one of these drugs is called codeine. The one that the pregnant mother was taking is a painkiller. Another one is tamoxifen, that a lot of women that had breast cancer typically take to prevent further cancer. So there are lots of drugs that have no effect, but through the conversion of the gene, it becomes an active substance, which is then further broken down later on. So codeine is such a prodrug. No effect in the body, but through its conversion through the 2D6 gene, it becomes the active form, and that is, see there, morphine. And morphine is a painkiller. That then is broken down further. So what happens? You take codeine, and for several hours, the body converts it into morphine. You have painkilling action, and then morphine is removed, and you're back to normal. So this is what happens here. What happens if I, as an intermediate metabolizer, take codeine? Codeine is only slowly converted, only half as fast converted to morphine. So we only have very low action. So the effect of the drug is much slower. It's longer because it takes longer, but the effect is much weaker than other people would have. Then there are 10% of population with poor metabolizer, they cannot activate it at all. And they sometimes get the drug because of pain, and then they go home, they can't sleep all night because of the pain of a operation or something, and they come back and say, I need a different painkiller, I can't stand it. And we would have known that this can't work because he doesn't have the right genes to activate it. And then here are the curious ones, where codeine through ultra-rapid metabolism is converted into morphine all at once. So it's a huge spike in morphine all at once. Very short action, but very high spike in the blood. So the status activates this drug in different amounts. And now back to this woman. The baby has died of a morphine overdose, and the mother was treated with codeine. And so the doctor said, okay, they think they know what happened. They did a test on the breast milk that was still stored in the fridge, and they found high amounts of morphine in the breast milk. And so they did a DNA test of the woman, and they found that she is an extensive metabolizer. I mean, she was taking codeine, it was immediately converted to morphine that created a huge spike in the breast milk. The baby then drank the breast milk and was slowly poisoned to death by morphine. And so you can see that the difference between, if we go back, the difference between normal action, weak action, no action, and overdose, deadly overdose in this case, is just the status of this one gene. So we all react very differently to how certain drugs affect us, and which drugs we should be taking and which ones we should be avoiding at all cost. So to take all of this into account, we are doing a very comprehensive analysis. It's more than 500 different genes are involved in this. And you will find out for every gene, if it's normal metabolizer, intermediate, or poor metabolizer, and so on, all of the other genes that play a role. And it's quite a comprehensive test. So we're testing all of it at once. And then we make a list of 2,500 different drugs, different active ingredients, not brand names, active ingredients. So pretty much all of the ones that are on the market. And they are alphabetically listed. So there's 250 pages. So you will just look up drugs that you might want to take, and then you can find the information. And you might find that it says abacavir is normal, you can use it normally, or warning, and then there's a page explaining to you exactly what you need to do, and caution. So those are the 3 levels that we have. Just to give you a little bit of insight of what we're doing here, there are scientific institutions that give guidelines of how doctors should use genetics for the choice or the dosing of drugs. And there are around 150 drugs that have such information guidelines. If you have this gene defect, reduce the dose to 5 milligrams per day or something along those lines. So those are the guidelines. This is the clinical guideline. That's what we would say that's 4 levels. That's very high level of scientific basis. The next one is drug label. That's 3 dots. That means the FDA has said, okay, in the drug label, when you take the drug, they're mentioning if you have this gene defect, take only half the dose. So that's a very, very high level. Then there's medically reviewed. Those are lots of studies have been reviewed by a group of scientists that focus on this. And they said, okay, based on the information we have, if you have this gene defect, you should half the dose of this. So this hasn't quite made it into the guidelines yet, because the guidelines just lag behind a few years. So those are to be in guidelines soon. And the last level is in scientific studies. So individual studies have shown a certain gene defect interacts with a drug. So those are all of the different levels that we offer, and we rate all of them based on this. Some other suppliers or some clinicians might justifiably say, I just want to know the guidelines because that's clear. I want to ignore the rest. That's okay. We believe it's good to know about all of it, and the doctor will then be able to check the drug that you are about to receive, and you can see, okay, this antibiotic is going to work for you, or let's use a different one. This is specifically important in psychiatric use, because certain antidepressants, they take weeks before they can actually work, and we could, through a gene test, already tell you that this is not going to work in you because you can't activate it. And especially if you're suicidal, it's very important that this drug works quickly. And so it's really important to have this information when you start treatment. And since the analysis does take a few days, that means that you need to have the whole analysis done before you get the new drug, because then you can just look it up. And so it's always good to have this report available when you get a new drug from your doctor.